Thank you all for joining us on a Monday night. I can see the numbers are coming in. Okay, so we'll get started. Thank you everyone so much for joining us on a Monday night for our COVID-19 oral antivirals in general practice session. My name's Bianca Bell. I'm the Director of Primary Healthcare Improvement at the North Western Melbourne Primary Health Network, but I would also like to acknowledge our partners in this session, Eastern Melbourne Primary Health Network and the South Eastern Melbourne Primary Health Network. So before we start, I would just like to acknowledge the traditional custodians of the land on which our work takes place at the Northwestern Melbourne Primary Health Network, the Wurundjeri Woi-wurrung people, the Boonwurrung people and the Wathaurong people. And we pay respects to elders past, present and emerging, as well as to any Aboriginal Torres Strait Islander people who might be with us today. A little bit of housekeeping. So we have Zoom webinar enabled for our session tonight. So all attendees are muted. We do have a Q&A function, so you can type your questions in the Q&A box. We'll answer those as we go along. Otherwise, there's time when we have the panel session at the end. This session is being recorded, but the questions will be anonymous to protect your privacy. And we ask that you please join the session using the name you've registered with so that we can mark your attendance, and that's mainly in line with making sure we can allocate CPD points. So if it's required for CPD points, please just change your name after entering the session. So just click on the participants button, hover over your name, and then you can rename. So if you've joined with, Ted's iPhone, you can rename that to your name. But again, that's really only for the CPD points if you need us to lodge those with the RACGP. I'm really excited with the panel that we have to present to you tonight. So first up, we have Dr. Lydia Upjohn. Lydia is an infectious disease physician at Monash Health. We then have Dr. Jeannie Knapp. Jeannie is a GP and the clinical advisor that works at the Northwestern Melbourne Primary Health Network. And we also have Meng Yap. Meng is a senior pharmacist at the Alfred and works on the Victorian COVID Therapies PBS prescriber helpline. So some of you may have called Meng and her colleagues, and if not, certainly by the end of tonight, you'll know about that service. So a jam-packed session that we have for you this evening. A quick agenda. We're obviously going through the introduction and housekeeping. Lydia is going to provide a clinical update on the oral antiviral drugs. Jeannie's then really going to give us dive into those tips and tricks for how to go about prescribing in general practice and making it sort of part of your day-to-day. We've then got plenty of time for questions to the panel, including Meng on there, and then a conclusion and obviously an evaluation at the end that we always do. So that is the end of the introduction slides. I'm just going to get up the slides for Lydia. Just bear with me one moment. Always a problem when you check these things and then an issue before the session, but I will drive Lydia's slides. No, I'm all good, Sadia. I'm just getting them open, hopefully. There we go. Okay. Just checking you can see those slides. Just checking you can see those slides.
I can see them. Thank you very much. Okay, I'll get started. So my name's Lydia Upjohn. I'm an ID physician at Monash, and I work through Monash HITH, and we have set up a very active early COVID therapies clinic that started off in the Sotrovimab days and now has evolved into prescribing antiviral therapies and giving remdesivir. And so my brief was to give you a bit of an update on where we are with COVID and then go through the early COVID therapies. So next slide, please. So this is just some information that I've got from the Public Health Unit about what is actually happening with COVID at the moment. And interestingly, probably a lot of this is to do with reporting bias, because we have active and good reporting systems for our cases. We're actually the 3rd highest daily new cases per capita of major populations. And that's kind of on par with the US, UK, Germany and Australia. But obviously we are testing and reporting a lot more, so it's probably biasing it somewhat. Next slide. This is the Australian situation report, and we're really this is going back to about this, a month ago. The numbers stopped there, and this is every day. So we're looking at kind of numbers bouncing up and down. But our hospital admissions on the right there, as you can see, Victoria is the blue line, have just been slowly climbing up over time, but not really having the big peaks and troughs. Next slide. In Victoria, you can see that our hospital admissions really have reflected those waves. So back last year, we had the initial COVID wave, then we had the Delta wave back in October, and then we had the Omicron wave in January, and our hospital admissions have really reflected that. And you can see that slow climb over time coming recently in the last month or two. Next one. But interestingly, our ICU admissions are really very low and have stayed flatlined really for the last few months. And we're really not seeing those hospital admissions that we did at the start to the ICU. So when I do an ICU ward route, I would see 3 patients with flu in ICU and no patients with COVID. So obviously our vaccination strategy and antiviral strategy is working at keeping patients out of ICU, but there's this steady stream of inpatients coming in, particularly elderly people with comorbidities into the hospital. Okay, next slide. And we have one of the lowest per capita death rates in the world, on par with Singapore and Japan. So you can see right at the bottom, we are actually doing very well in terms of COVID death rates. So again, it's our vaccination strategy, high vaccination rates that are really doing this, I think. Okay, next one. So I thought I would now get on to the early antivirals, and I was thinking big picture about it. Early antiviral therapy is not a new concept for us. We use it in flu, so there's neuraminidase inhibitors such as oseltamivir and zanamivir, which we give early to prevent people getting severely ill and to shorten the duration of symptoms. We treat early in HIV during seroconversion illness to prevent progression. And we treat hepatitis C early as well in an effort to prevent problems. So early antiviral therapy is not a new concept. Next slide. But it is kind of a new concept in, apart from flu, in respiratory viruses. And really the patient profile that we're talking about is within the first 5 to 7 days of symptom onset, and all patients must have mild to moderate respiratory disease. They can't be hypoxic, they can't be tachypneic, they can't be very unwell, and they can't be in hospital for COVID in particular. They can be in hospital for COVID with some other kind of problem, as long as they've still got mild disease. And the drug targets viral replication or viral entry into cells. And the whole aim of early therapies is to prevent progression of patients to hospitalisation and death. And that's what all of the studies looked at. They looked at hospitalisation and death. They didn't look really at the patient's symptoms. So the secondary aim is to shorten duration of illness and severity of illness, but that really was not looked at well in the studies. So when patients ask you, well, what's this drug going to do for me? You'll have to be honest and say, it's going to prevent you getting sick and going to hospital, and then it might help you feel a bit better, but we don't really know. Next slide. So here are the early antivirals for COVID in particular. There's a whole group of monoclonal antibodies. There they are, sotrovimab, casirivimab, imdevimab, bamlanivimab, bebtelovimab, which are all incredibly hard to say. And they're given over an IV infusion over 30 minutes as a once off. So quite easy to give, but have generally, they're generally not being used now. Bebtelovimab is the only one that's active against Omicron, and it is not available in Australia. Then we've got the two oral antivirals, which are the focus really of tonight's talk, which is nirmatrelvir or ritonavir, I'll just say Paxlovid from now on, and molnupiravir, oral over 5 days. And then there's remdesivir, the IV antiviral, which has to be given over half an hour and has to be given over 3 days. So awkward to give, but a useful drug. Okay, next slide. So this is the best graphic that I have got to kind of understand where these antivirals sit in viral replication. So as you can see down the bottom, you've got at day 0, there's a pre-symptomatic phase where viral replication is increasing. Then you get this period of mild to moderate illness over 0 to 7 days. And then you've got that progression at about day 9 to 10, that proportion of people who have developed the inflammatory syndrome with COVID have progressed to severe illness and critical illness. And the whole aim of these medications is to concentrate on that early, highly replicative viral phase, squash that down, and prevent patients progressing along to severe illness. Before you even infected with COVID, there's also Evusheld, which I'm not going to talk about in this talk, but that's a monoclonal antibody that we can give intramuscularly, hardly say that, to prevent people getting COVID. But really what we are concentrating on now, next, if you push the slides button again, please, is here. We're looking at this group of drugs here. Okay, next slide. Okay, so I'm going to talk about the monoclonal antibodies because there's still a bit of confusion out in the community about whether you can give sotrovimab. So sotrovimab was our first monoclonal antibody that we used for COVID, but unfortunately it was very, very good, very effective, easy to give, but it has significantly reduced activity against BA2. So generally no hospitals much are giving sotrovimab anymore around Melbourne. Again, there was a drug called Ronapreve, casirivimab, imdevimab. Again, it was not active against Omicron, so not stopped being used. Evusheld, which is really only studied for prophylaxis, and it maintains some activity against Omicron. And then bebtelovimab, which is effective against Omicron, but unfortunately not available in Australia. Okay, next one. So here we have the early oral therapies, which is where we really want to concentrate our efforts on. And there's 2 of them. I'm sure you're familiar with them. Paxlovid, which is a protease inhibitor, and molnupiravir, which works by inducing lethal mutagenesis in the virus. Next slide, please. So the first drug to talk about is Paxlovid. As I said, its action is it's a protease inhibitor, and it inhibits long protein chains into the virus that the virus needs to replicate. And both of the components are actually protease inhibitors, but it's the ritonavir component that boosts up the level of nirmatrelvir to enable it to be effective, so I think about it. And it comes in 300, 100 milligram tablets, which have to be taken BD daily for 5 days. So 2 nirmatrelvirs and 1 ritonavir. And the study that was, there's one big study called the EPIC-HR study that looked at Paxlovid use. And it looked at 770 non-hospitalised adults at high risk of progressing to severe illness. And you can see there the risk factors that they had: diabetes, obesity, cardiovascular disease. There were really very low numbers of immunosuppressed patients and patients with chronic kidney disease. And all of the patients in this study were unvaccinated. And it was really very efficacious. So when used within 5 days of symptom onset, there was an 85% risk reduction in your risk of progressing to severe illness. So 1% in those who took Paxlovid and 6.7% in those who took the placebo. So very, very effective. Next slide. But only one study. The really major issue with Paxlovid is the cytochrome P450 interactions, which make it a difficult drug. It is likely to be contraindicated in about 25% of eligible patients. And the problem with it is if you give it with inducers of the cytochrome P450 system, you lose virological response. So there's a long list of problems with the drug. You have to be careful with renal function in particular. There's a dose reduction that needs to happen if their eGFR is 30 to 60 and you give 1 tablet of nirmatrelvir and 1 tablet of ritonavir. And if their eGFR is less than 30, it's contraindicated. So it's very useful if you have some recent UNEs on patients, because that gives you a good idea. But it can be difficult if you don't have access to recent UNEs. With hepatic impairment, there's no issues with mild to moderate hepatic impairment, and you avoid it if severe. In reality, if we're prescribing these things during telehealth consultations and patients don't know, we can't assess them as to how severe their liver disease is, I would generally avoid Paxlovid just because we really don't know what their liver disease status is like. And just note that you can't crush Paxlovid. So that can sometimes make it difficult for patients. Okay, so on the right there, I've got a little table showing just some of the drug interactions with Paxlovid, and we'll talk more about it, but they're extensive and need to be checked for each individual patient. Okay, next slide. There is a very useful website called the COVID-19 Drug Interaction website. It's the Liverpool, University of Liverpool put it together. It's very easy to use, it's straightforward. You type in Paxlovid and you type in the drug that you want to check, and it gives you a green light, an orange light, or a red light as to whether you can use the drugs together. But just be careful with it, because there are a lot of some drugs that are just not listed on the University of Liverpool Drug Interaction website, and be careful with chemotherapeutic agents because they're not on there and you have to check them separately. Okay, next slide. There is a really good flowchart on the Department of Health website, Early COVID Therapies page, that gives you some useful tips as to where you can easily use Paxlovid, which is the green kind of drugs. They're okay. In particular, corticosteroids are fine, azathioprine's fine, and methotrexate's fine. So immunosuppressed patients on methotrexate and steroids, you can give Paxlovid to, no problem, and that's very useful to know. There are medications that orange light medications that you just need to adjust or warn patients about. And it requires a bit of input from us to do things like warn patients that if they're on a calcium channel blocker, to maybe check their blood pressure or halve their dose, depending. Sometimes you have to adjust inhaled beta agonist therapy. And there's some medications that just interact with Paxlovid badly and you should not give it. For example, tacrolimus and cyclosporin. So a lot of our transplant patients, we would consider giving remdesivir to. Good. Okay, next slide. I wanted to briefly talk about Paxlovid rebound, which is a syndrome that has been reported in the trials. And basically, it's a recurrence of symptoms or a negative to positive test after completing the course of Paxlovid. And the CDC have put out an official health advisory about this about a month ago. It was reported in a very small number of participants in that study, the EPIC study, and there didn't seem to be an association between these rebound symptoms and an increase in hospitalisation or severe disease, but the numbers were too small really to say anything useful about it. It does not seem to be because of resistance to Paxlovid, which is useful to know. And the CDC make a recommendation that you don't retreat with another course of Paxlovid or another antiviral, but you just advise the patients to re-isolate because they may be infectious if their symptoms rebound. So it's something I talk to patients about. I warn them about it, and particularly the immunosuppressed ones, I will talk to them about this. Okay, next slide. So molnupiravir is the next cab off the rank. It has a different mechanism of action. It's a viral genome replication error drug. It causes lethal mutagenesis in the virus. And you have to take 4 tablets, 800 BD for 5 days. And the study was the Move Out study, and it included 1,400 outpatients, and it had our usual list of inclusions. They had to be less than 5 days of illness. They had to be symptomatic. They had to have mild disease. And its efficacy was actually there was a 30% risk reduction in the study, but actually when you look at it, there's 6.8% risk of hospitalisation or death in the molnupiravir group and 9.7% in placebo. So they're very close together, and there's some question about the efficacy of molnupiravir. However, it's very well tolerated and it's easy to prescribe. So, and it's very few drug interactions. So it's a useful drug, but its efficacy is poor. Next slide, please. So there was some discordance between the interim analysis in the study and the final analysis. It's got fairly low efficacy and it's teratogenic in animals, which is the big problem. And it's absolutely contraindicated in pregnancy. It's contraindicated. Contraception is recommended until 4 days after the final dose in females, and I generally don't prescribe it to women of childbearing age. And for men, contraception is actually recommended for 3 months in men who are sexually active with a partner of childbearing potential. So something to bear in mind carefully with your patients. It's really a 3rd line only drug. And I consider it something for those that aren't suitable for Paxlovid and aren't suitable for remdesivir. It's useful in those in residential aged care facilities. Okay, next slide. And then remdesivir. So remdesivir is an IV antiviral given over 3 days, 200 milligrams, 100 and 100. It binds to viral RNA and inhibits viral replication. It's active against Omicron, which is very useful. And it was studied in a trial called the Pine Tree trial, and it used a slightly wider symptom window, so up to 7 days, whereas our other oral antivirals were 5. It looked at unvaccinated outpatients, the same kind of risk factors for disease progression, a small pool of people who were immunosuppressed, and it was very effective, actually, probably on par with Paxlovid. So it had an 87% risk reduction in hospitalisation or death. So a very effective drug, but has this awkward IV course over 3 days. Next slide. Okay, so this is the prioritisation matrix, which is published by the Department of Health, and it basically sets the criteria that we can use to prescribe the drugs through the National Medical Stockpile. There is a discordance between the National Medical Stockpile criteria and the PBS criteria. But in general, just because of hospital constraints and staffing constraints and all those things we're all struggling with at the moment, most of the hospitals are really trying to prioritise their prescribing to the most high-risk groups. So we're never making it down, for example, to the people at the lower part of the fully vaccinated part of Group 3, or any of the people in priority group 4, which is the green group there. So next slide, please. This is really, I've highlighted in red, the group of patients that we have been trying with our clinic to really reach quickly. We target the immunosuppressed, we target the unvaccinated and the elderly, and we target those who are partially vaccinated and have high risk comorbidities. So even though the PBS criteria kind of don't allow, and the hospital criteria don't really match up, we're not really ever able to get down to that priority group 4. Okay, next slide. So this is my very simple decision-making flowchart, which I go through for each patient. The first thing I do is assess whether they're eligible for an early therapy. So have they got a positive result? Have they, through a RAT or a PCR, have they registered it with the Department of Health? And when was the first day of their onset of symptoms? If they're asymptomatic, we're not going to prescribe any therapies. We're just going to say getting contact with us as soon as you have a symptom. And the first day of symptoms is the first day of their anything that happens to them, whether it be a fever or a sore throat or a cough. And the next thing to do is assess whether we can give them Paxlovid, which is the first priority drug. And then the major thing is, what's their renal function? Do you know what that is? And what's their drug list? And are there any contraindications to me prescribing Paxlovid? Do I have to adjust any medications? And you do everything that you can to try and prescribe them Paxlovid. And if you can't, the next thing to assess is whether you can prescribe them remdesivir. And remdesivir, as I said, awkward to give, has to be given through hospital pathways, but kind of essential if we're looking at highly immunosuppressed patients who can't have Paxlovid and can't have any dose adjustment for their immunosuppression, are all on cancer chemotherapy, which prevents them getting Paxlovid. So if you can't give Paxlovid, you can't give remdesivir, then you need to assess to see if you can give them molnupiravir, which is usually pretty easy. Most patients can have that. And then you treat the symptoms and observe them. Okay, next one. So here's my top tips for prescribing therapies. Overall, prescribing these therapies is moving away from hospitals to the community. The hospitals in general are going to be prescribing just to the tip of the iceberg and trying to get the very high risk patients on the medium high risk pathway, COVID pathway, their drugs quickly. And we are moving away from just prescribing through the hospitals, and it's going to move to GPs. Hospitals are generally trying to prescribe systematically to high-risk patients via lists generated from COVID Monitor. At Monash, we've had a self-referral system that's worked reasonably well, but we're going to shut that down shortly. The next tip is to prioritise Paxlovid, number one. Think about that first of all and try as hard as you can to prescribe that safely for your patient. And if you can't, work yourself down that decision-making tree. Make an antiviral plan with your high-risk patients prior to them catching COVID, so you know quickly which drugs, what you're going to do. The earlier the patient starts therapy, the better the outcome. So it's ideal, you can't wait a day and then wait another day. You have to try and get them to start pretty much the day that they, get in contact with you, if possible, and the earlier on, the better. The Department of Health website for early therapies is very, very useful, and I check it all the time. And it's got a list of who to contact if you want to refer a high-risk patient for remdesivir, and to look at how to contact the COVID pathways, because that's generally the way in for patients who you've got questions about or you want to access remdesivir for. And the Alfred are providing this very useful pharmacy helpline for advice. Because we have a pharmacist on our early therapies clinic who we run every single patient by. So that's very useful for us. But out in the community, you don't have that luxury. So the pharmacy helpline is very useful. Okay, next slide. And this is my general summary of early COVID therapies. There are no monoclonal antibodies currently recommended or widely used now in Australia. So you can kind of watch this space for them. There may be some that become available in the future. Paxlovid is the preferred option if there's no significant drug interactions. IV remdesivir is an option that you have to think about for high-risk patients, but it depends on your hospital network and whether it's offered. Any doctor can prescribe these therapies, I say, through the hospital pharmacy or the PBS, and this area is constantly changing, and it will change again, and we all just have to kind of get used to it. We have to get used to changing criteria and checking websites, and I think that's just what's going to keep happening, actually. Keeps us on our toes. Okay, next slide. So I just wanted to give you a look at what we were doing in Monash in particular. So we have had nearly, probably now about 2,000 referrals, I would say, over time for assessment in our telehealth clinic. We have given, when we had sotrovimab, we gave 1,400 infusions of sotrovimab. to date, and this is a little bit old now by a few weeks, we've given 210 courses of remdesivir. So that's ×3 for each. So it's a lot of IV use, and we've prescribed a lot of oral Paxlovid and a tiny bit of molnupiravir. So that's been all our work to date. Again, this is all changing. We're going to be changing our models around as the prescribing moves towards the community. But hopefully that we can still provide, you know, a good service and a pathway in for your high-risk patients. Okay, that's the end.
Thank you so much, Lydia.
Slide at the end.
Oh, sorry. I cut you off for the thank you slide. Apologies.
It was all my thank you slides for all my helpers.
So just while we're getting Jeannie to get up her presentation, I'm just going to check for questions. But Meng, did you have anything that you wanted to add to that? I know that you work on the helpline.
Not really. I think like the only thing to add is like, you know, like everyone's like all GPs or doctors in the community are welcome to call this hotline, you know, just to bounce off any questions, or if you need like someone to have advice on, especially the drug interactions for Paxlovid, we can provide that assistance as well. Yeah.
So we do have some questions in the chat, but I might leave them to the panel section. And I can see that there's a question in the chat about what's the number of the hotline. And I know Jeannie is going to go through that in a moment. So I will hand over to Dr. Jeannie Knapp. Thanks, Jeannie.
Thanks, Bianca. Thanks, Lydia. Lydia, there's a couple of questions in the Q&A that might be right for you to answer.
Have a look.
Good evening, everyone. Thank you for coming along on a Monday night. I have to say it's very odd not being able to see any participants, just my screen. But I'm going to talk about improving access to these treatments for our patients, gaining confidence in prescribing, and also improving our workflows so that we can make this easy to prescribe for our patients. And why is it not going? I'll go down there. So my name's Jeannie. I'm a GP. I practice in Richmond. I'm also the clinical advisor to the Northwest Melbourne PHN. And I laughed when the information for this said an expert commentary, because my only expertness is in my expert averageness. I'm very much an average GP, and I have come to this from a standing start. And about 2 weeks ago, I was given a gold medal for whinging about antivirals being just another thing that's being dropped on top of us in the middle of this storm that is COVID. But I've had to really kind of sit back and think about what are the advantages to GPs prescribing these for patients. And, you know, all health services are stretched, and these medications are potentially game changers for our patients in terms of, as Lydia said, reducing hospitalisation, reducing death. And who better to know our patients well and to provide that wraparound care to our patients than us as the GP? And so we are an ideal place to be prescribing these for our patients. I'm going to, these are the things I'm going to talk about which really mirror the patient's journey to getting the prescription. So I'm going to go over the PBS criteria. I'm going to talk about pre-infection planning, about testing tips for our patients, about access to appointments for our patients, and we're going to talk about making prescribing feel comfortable, and talk about what happens at the pharmacy when the patient takes the prescription to the pharmacy. And I'm going to give us 4 key resources that if at the end of this we bookmark those 4 key resources, we're going to feel confident prescribing. So the first thing is the PBS criteria, and my summary is it's easier than it looks. So I'm just going to break it down to the first part. You have to be confirmed positive, symptomatic, not in hospital, and within 5 days. Now, this really the spirit of the PBS is that the patient actually has COVID. It's not prescribing for prophylaxis or just in case you get it next week. The patient has to be symptomatic, they have to have the COVID, and the confirmed positive is I have a conversation with the patient and we talk about their positive test. It doesn't have to be more complicated than that. And then there's really these four areas. So the over 65 with 2 risk factors, over 75 with 1 risk factor, the over 18 and immunocompromised, or Indigenous and over 50 with 2 risk factors. These drugs are expensive. They cost just over $1,000 on the PBS. And although I'm sure that the overall health cost is negative by reducing those hospitalisations and reducing those deaths. And there has been requests from our higher powers to not prescribe privately for patients, to reserve the stock that's available for those at high risk. And this is really all about targeting the people at highest risk. Another place that we can get that information is Health Pathways. Health Pathways is a fabulous resource for all things COVID. So the risk factors, really, this is just there for reference. I'm not going to go through them all, but they all make sense. Undervaccinated, residential care, neurological conditions, obesity, diabetes, etc. So remember, if they're over 65, they have to have 2. If they're over 75, they have to have 1. Or Indigenous and over 50 and 2. So Indigenous over 50, treated like over 65. And the immunocompromised, again, they're all laid out there, but we're very familiar with these from our days of doing vaccine eligibility. The kind of extra ones to note at the bottom here, Down syndrome, cerebral palsy, or people in disability residential care. Oh, there it is. So the next kind of part of the journey, so we've sorted out our PBS criteria, some pre-infection planning. Now, this is really about time spent now, trying to reduce time at the time. When we get that call from a patient that they're COVID positive, if we've already done some pre-infection planning, hopefully that will make it easier for us on the day. And I know I kind of feel a bit, overwhelmed by it all at the moment, but hopefully some, doing some pre-stuff will make it easier down the line. So COVID treatment plan for the patient. Have we got time to contemplate proactively identifying patients? PenCat unfortunately hasn't given us a recipe, but we can do some adapting, and maybe we can proactively identify patients and call them in for a COVID treatment plan. Which of our local pharmacies are stocking? While that was a big concern, I know initially, I know now most community pharmacies are stocking it. And also considering doing the same for our RACF patients. And that while molnupiravir, which I still can't pronounce properly, is in stock in the rest and the nursing home, that doesn't mean that we can't prioritise them for Paxlovid. We've heard from Lydia that Paxlovid is the drug of choice. So we can pre-plan with them. We can think that Paxlovid might be the ideal. We can even pre-prescribe it. So it's on the chart, ready to go if you get that call at 7 in the morning. So what does a COVID treatment plan look like? Again, this is time now to try and reduce time later. This is about trying to improve our workflows. So an example of a COVID treatment plan might be having discussed with our patient, are they eligible or suitable for GP prescribed oral antivirals should they become COVID positive? If they're not eligible for GP prescribed, what are the other pathways to treatment? How does the patient let me know so that I can make sure they get referred into Lydia's service? And I know they should be triggered by the treatment pathways, but we all know that some patients fall between the cracks. We're going to reinforce testing early if they become symptomatic, and we're going to reinforce how to access the treatment, how to indicate that urgency. And as I've already said, pre-deciding what prescription that we might prescribe for them, so that when the call comes, we've already gone through, checked all the drug interactions and know whether or not we're going to be prescribing Paxlovid. We're going to make sure that drug list is up to date so that if I do refer them to Lydia's service, they've got a nice up-to-date drug list. And it's a fabulous time to make sure they've got an up-to-date eGFR. And in an ideal world, we'd record this in a way so that if it's my colleague who's seeing them on a Saturday morning, they can see that that conversation has already been had. So testing, we want to educate our patients how to test. Some elderly patients in particular are struggling sometimes with how to use the RAT test, where to get the RAT test from. You can still get them from the state testing centres. People with concession cards can get concession pricing, and testing early, and also educating our patients when to have a PCR. We don't want someone who's symptomatic, at risk, been exposed, sitting at home for 5 days waiting for the RAT to become positive. Maybe that might be a time to go and get an early PCR. And the importance of registering that result. Lydia mentioned registering the result, but telling our patients why we register it. It triggers a whole bunch of support through the COVID pathways, which are both clinical and social, and reinforcing how to seek care if they do test positive. So access to appointments. And I can just again reiterate that it's extraordinarily challenging in the current environment to be contemplating additional appointment stress on top of what we're already doing. And especially in something that is so time critical as early COVID therapies. You could maybe consider setting aside some daily urgent COVID treatment telehealth appointments that are just locked in. Our system lets us have special colours for different appointment types, and so you could have some little purple appointments for people to be locked into, that they know they can phone up on the day and get an appointment. And with that comes some reception training about urgency, making sure the receptionists know that if your patient phones up and they're looking for early COVID therapies, that how urgent that is. Make sure you've got a backup plan for when there is no availability, because we know that realistically not all of our patients will be able to see us within the time frame sometimes. So maybe we could refer to a GPRC for COVID care, and making sure we know those local treatment pathways. So when am I still going to use the hospital services? And Lydia's partly answered this for us. But and it's just, as she noted, it's worth noting that the PBS criteria and the National Medical Stockpile criteria aren't the same. And to further complicate matters, each different hospital service also have different criteria. Working in Richmond, I've got 5 hospitals that my patients might be referred to with 5 different criteria, 5 different ways to access, and it's impossible to kind of keep your head around what's what. So anyway, one lot that we might refer to the hospital clinics still are the ones who don't meet the PBS criteria, but you might be still concerned about. And I've put a couple of suggestions there. Maybe a young MS patient who's not on immunosuppressants. Maybe a younger Indigenous patient who's under 50, not fully vaccinated with comorbidity. So they might still count as a high-risk patient even though they don't meet that PBS criteria. Those patients who are at high risk for whom Paxlovid is contraindicated. So these are the ones that will fall into that remdesivir flowchart that Lydia showed us. Pregnant and breastfeeding patients, they can't have either of the 2 that we've got access to. Patients under 18. High-risk patients day 5 to 7, and we also, if you were working in a nursing home with a big outbreak, you might want the hospital service to help with just the sheer numbers there. And there's a little link in the slides there to the Clinical Evidence Task Force tool to stratify that risk, because we talk about, well, high risk, low risk. Well, who is high risk and who's low risk? And it's all in this lovely tool here. And again, a shout out for health pathways. Every single time back in the day when I was referring for Sotrovimab, every single time I go onto health pathways, I find out where the patient lives, I find out which my local hospital is, and I send them off to the right place for that. The next bit is feeling comfortable prescribing. And I think we should remember that that comfort with prescribing comes over time, that the more we do it, the more comfortable we'll feel, the more we'll get a fit sense for this drug's a yes, this drug's a no. And I was reflecting when I was writing this about when NOACs first came out and how I clung on to warfarin like an old friend. And now I can prescribe a NOAC in my sleep. And the same will happen for these early COVID therapies. We will increasingly become comfortable with them. And like I said at the start, I'm going to give us 4 tools to bookmark that will make us feel really comfortable. Like any prescription, we're asking ourselves kind of similar things. What medication is preferred? What are the contraindications and interactions? And particularly for Paxlovid, what is their cognitive ability to do a dose adjustment or withhold? So if they've got impaired EGFR, they may have to adjust the Paxlovid dose. Depending on what you find when you do the interaction checker, you might have to withhold some other treatment. And do they have the cognitive ability to do that? Can those interacting medications be safely withheld? And is the medication available in the time frame? And don't forget to tell our patients about the common side effects. One of my colleagues who had this prescribed said, you must remind people about the awful metallic taste you get in your mouth. So which medication is preferred? And Lydia has already answered this, but I'm just going to reinforce that Paxlovid is the medication that's preferred. We're aiming to reduce severe disease and hospitalisation, but it also reduces duration and transmission. And remember that 90% of the deaths in Victoria were in the over 70s. So that's why that PBS criteria are really targeting this high risk group. And Paxlovid reduces that risk of severe disease by 90%, whereas the Molnu one only reduces it by 30%. So it's a good alternative for lower risk patients if Paxlovid's not suitable, but Paxlovid is our drug of choice. And while we can give it up to day 5, ASAP is best. And this is, again, really here just for reference, and that's a slightly more complicated version of that lovely flowchart that Lydia gave us in her talk. But again, the take-home message is Paxlovid, Paxlovid, Paxlovid. If high risk and can't take, refer. But if lower risk, we're probably okay to give them molnupiravir then. So, and again, Lydia's talked about these contraindications, and this is partly here for reference. We've talked about that renal impairment, the hepatic impairment, the drug stuff. The other one is the low weight. So it's not for, basically not for children, the pregnancy and the breastfeeding. And then here's my first thing to bookmark. If you bookmark this University of Liverpool drug checker, your life will be so much easier. MIMS is no good for this. This is just an awesome resource. Lydia's already talked us through how to use it. And it is, it's not only does it tell you it interacts, it tells you what to do. Withhold this drug, reduce this dose. It's fantastic. And this is my second thing to bookmark, and this is the EGFR table. And this just reminds us, depending on what that EGFR is, if it's normal, it's the 2 tablets and the 1. If it's reduced, it's the 1 tablet and the 1. And if it's less than 30, it's not at all. So this is a really good reference to just quickly look at and be able to adjust the dose depending on that renal function. And then the EGFR recency conundrum, and I'm sure we will talk more about this in the panel discussion later. But essentially, an EGFR within the last 6 months is usually considered okay, especially if it's usually stable, but also use your clinical judgment about your patient. If you know your patient has no particular renal risk factors, they don't have hypertension, they don't take drugs that affect their renal function, they're not vomiting with their illness, then maybe more than 6 months will be okay. But if you're not comfortable with the no recent EGFR or any doubt about stability, it's the same flowchart as before. If it's high risk, refer to ID. If it's low risk, consider molnupiravir there. So molnupiravir, as Lydia said, much easier to prescribe. The big one is the pregnancy. Neither women nor men can get pregnant afterwards. Men for 3 months, women for the 4 days, and the breastfeeding, but otherwise pretty well tolerated. And here's our third bookmark, and this is the Alfred hotline for prescribers. We've got Meng on the line. She's going to talk with us later, but this is a service that's provided 7 days a week for PBS prescribers. It's staffed by Alfred pharmacists who are experienced in dealing with these medications. They can help us with the tricky ones. They can help us with the quetiapine, which is tricky. They can help us with what we can withhold and how long we withhold it for. And the other thing to note is that at the moment, there's very little wait time ringing them. You're not going to be on a hold for 20 minutes. You can pick up the phone, ring them, and they're going to answer. And here's our fourth bookmark. If you bookmark those 4 things, you're going to have the confidence to prescribe, and particularly these health pathway pages. The RACGP resource is useful, but a little out of date already because it came out before the PBS listing. And that Vic Department of Health Clinical Decision Making tool, which is the one that Lydia has done a much better job of condensing, and the COVID-19 Evidence Task Force Decision tool, which is the one to help us decide on risk. So then we've done all that pre-planning. The patients tested, they're positive, they've contacted us, we've prescribed it, and now they go to get it from the pharmacy. Now most local pharmacies are now stocking. And the supercare pharmacies particularly are guaranteed stock, but essentially all of the local pharmacies now are having it in stock. Consider adding the EGFR to the prescription so that the pharmacist knows it's been considered, and even consider contacting the pharmacist, especially if it's a pharmacist that you don't deal with on a routine basis. Make sure those contact details are correct, because the pharmacy might want to contact the patient. And talk to the patient about which pharmacy they should go to, and check that they have a method to collect. Most people will be able to get someone to collect it for them. Some of the pharmacies are couriering, using a courier service. So in summary, early access to oral COVID antivirals is a game changer, and we can improve outcomes for our patients. Prescribe Paxlovid if we can, and don't forget that Liverpool Drug Checker, the EGFR table, the Alfred Pharmacy Hotline, and Health Pathways.
Thank you very much, Jeannie. That was really useful and some really practical sort of tips that can be implemented. So we do have some questions that I might just start to put to the panel. So one of the questions was around, is prophylactic antiviral for COVID-19 recommended as for HIV?
No is the answer to that. There is no prophylactic antiviral like you would use PrEP or pre-exposure prophylaxis for HIV. The one thing to say about that is there is Evusheld. Evusheld is a prophylactic antibody that is given intramuscularly and lasts for 6 months, and that's for a particular cohort of immunosuppressed patients. So it's for kidney transplants, liver transplants, and for people who have got hematological malignancies such as CLL, CML, and B and T cell depleting therapy. So it's for a very high risk subset of patients, and the hospitals are trying to sort through their lists of patients basically and locate them and give them offer them Evusheld. So that's our prophylactic therapy.
Great, thanks, Lydia. Next question, does the patient's COVID-19 vaccination state affect their eligibility for Paxlovid?
So if you look at the PBS criteria, they are, and Jeannie went through them, it does influence it somewhat, but if you're elderly and up to date with your vaccinations, you are still eligible. If you have one high-risk comorbidity and you're more than 75, it doesn't matter what your vaccination status is, because we know they've looked at it and they've said it doesn't matter if you're the most people who are getting hospitalised are actually elderly, fully vaccinated people. So they have tried to set, I think, the PBS criteria to reflect the kind of people that are coming into hospital. So you have to be a bit careful, but you can definitely prescribe it to people who are fully vaccinated. But
and the unvaccinated counts as a risk factor.
That's right.
So either is fine.
Yeah, to be specific, it's less than 2 vaccines. So anyone that has 0 vaccination or 1, is one of the risk factors.
Great, thank you, panel. How do you differentiate rebound symptoms from long COVID?
Usually rebound symptoms, so if you stop the Paxlovid at day 5, then your respiratory symptoms will come back soon. So your sore throat will come back and your cough will come back, and all of those respiratory symptoms that you had at the start will come back. So it's not the kind of long COVID syndromes that we're talking about with fatigue and neurological syndromes and things like that. It's particularly respiratory symptoms.
Great, thanks. So the next just relates to the data. So can the data from the efficacy studies of Paxlovid and molnupiravir be extrapolated to the Australian residential aged care population? This person has lots of nursing home patients in facilities with outbreaks.
None of the studies there's no specific studies in people in residential aged care facilities. We really only have one big study on unvaccinated individuals for Paxlovid, and there is a partially vaccinated study that the results are still coming out. All of these antiviral studies, we are extrapolating from them and increasing the range of patients who are eligible compared to the strict eligibility criteria that they used for the study. But we are doing that because we are saying, look, they're effective. We've got a population that will benefit. We should prescribe them if we can. And all of the data on population effectiveness is going to really come from observational data later, so pooling information retrospectively and looking at big numbers in the community. But I think we'll have to wait a little bit longer for that. But you can definitely use it for residential aged care facilities. It's just, it takes a long time to go through all their drugs. So it's more time consuming, and you're probably going to have less bang for your buck doing that, because a lot of them will be on medications that will interact. But that doesn't mean you shouldn't do it. Yes.
Yeah. Thank you. So this is probably the full panel. Last month, GPs were told not to stop the contraindicated drug for Paxlovid. Is this still the case? And Lydia, this might have referred to your presentation. What do you mean priority Paxlovid?
I'll prioritise, it's like what Jeannie said. I think at the start, a lot of GPs had access to molnupiravir. So we're prescribing it because it was the antiviral they could prescribe and had access to. And now we've got to change our thought processes and think, the first thing that I'm going to think of is not only is the patient's symptoms in the range, the next thought process is, can I prescribe Paxlovid? Let's look at your EGFR, let's look at your drug list. So that's what I mean by prioritise Paxlovid, just what Jeannie was saying. That's what you have to put your efforts into. Yes.
Excellent, thanks. Meng, did you have anything you wanted to add to that from a pharmacy point of view?
I think I'll add to the question about like not stopping contraindicated drug. I think it really depends on the drug itself, like how long the half-life. If the drug half-life is very long, like amiodarone, then we wouldn't even recommend like Paxlovid, because it's just too complicated. And some drugs like the patients can't afford to stop. Yeah, so really case by case, like for example, statins, if there's no risk of stop, like if the risk is low of withholding it is low, then most patients could afford withholding it. But like what Lydia's saying, like calcium channel blockers, you can either consider withholding it or continue and monitor for symptoms of hypertension, or even halving the dose. Yeah, so it really depends on the drug, but the Liverpool interaction checker is a really good resource because it does provide guidance on, what are the options that we can consider as well. Yeah.
Thank you.
And just a shout out.
There's lots of drug. I was just going to say the drug interactions are complex, but you do get used to them. So you get used to the opiates interacting and whether you can adjust them, and it becomes easier over time.
And just a shout out, Meng, for your own service. I think the the easy ones we'll get familiar with, and the complicated ones, we've still got you to phone and get some advice from it, specific case-by-case advice for each patient.
Yeah, absolutely. Because like Lydia mentioned, there's some drugs that are not in the interaction checker. So as a pharmacist, sometimes we have to look at other resources and look at the drug profile and then make a clinical decision based on, the type of CYP enzymes that are involved as well. Yeah.
Yeah, I think sometimes my pharmacist on our therapies clinic can take sometimes 45 minutes looking up different resources, trying to figure out a drug, and then we have come to some kind of conclusion.
Yeah.
And yeah, it can be challenging.
Yeah, that's right. So sometimes you may need time to get back to a question as well. Yeah.
So certainly there was a plug in there for the pharmacy line, but also the Liverpool drug checker. And someone has asked in the questions whether you can be emailed those links to sort of Jeannie's bookmarks, but we'll certainly make sure that is sent out the next day or two.
The other thing, Bianca, sorry to interrupt, but I did forget to say this at the beginning, that we are working on getting all of the information in that presentation down to one page. that'll come out soon as we've got it live, and just be able to have all those resources in that one place.
Yep, great. A question here, and is there any role for oral or inhaled corticosteroids for treating COVID in the community or for inpatients?
For mild disease, I think there is a role for inhaled corticosteroids. There's 2 out of 3 studies that showed they were moderately effective. Probably not as good as Paxlovid, but or if not a bit more effective than molnupiravir. So I would definitely, this talk wasn't about oral, sorry, I've been hijacked by my 4-year-old.
Ultimate multitasking.
I would definitely consider it if your patient can do it. I would prescribe inhaled steroids, budesonide, if you couldn't prescribe Paxlovid. Consider that as well. So I'd probably put inhaled steroids a little bit higher than molnupiravir myself, but that's not to discount molnupiravir has some effectiveness. So it's a little bit of an individual choice, but yes, in hospital we prescribe them for mild disease too, but not for severe. For moderate to severe disease, we use dexamethasone orally.
Great, thank you. There's a question here just around how to refer the patients for antivirals when we are not sure about the eligibility.
Yep. You need to check the Department of Health website. And Jeannie, do you want to talk about that in particular?
All Health Pathways. Health Pathways is a beautiful one-stop shop. On the COVID treatments page, it's got where does your patient live, what area, and then it tells you the phone number, the email address.
Yep.
And I find for most of the services, you phone and you speak to either an ID consultant or registrar on the end of the phone, and that you either fax or email a referral. So they're seeing the patients really responsively. But Health Pathways is the one-stop place to get all that information. And if you don't know how to access Health Pathways, Bianca will tell us that you contact your local PHN.
Correct. Yep.
And just to be aware that things are changing in the pathways as well. There's a lot of changes at the moment. So you just have to be aware that the services are changing in the hospital as well. But also that the hospitals are working to get those prescriptions to the highest risk patients as well in the background. So you may find that your high risk patients have actually already been, the hospital's already contacted them. That should be happening.
Great, thank you. Just a question in relation to long COVID. Can Paxlovid be used in long COVID? Some US studies are suggesting that might be the case.
I haven't seen any evidence to that effect yet.
Lydia, is there any evidence that that if we prescribe Paxlovid for someone on the PBS criteria with COVID, that it can reduce their chance of getting long COVID?
No evidence
either. Yeah.
No.
Yeah.
Hopefully that will be the case, but I don't think we can tell our patients that or ourselves that yet. We don't have that evidence.
So another question here around, can I start Paxlovid and draw a U&E, then modify the dose depending on the result within 24 hours?
I think that's a reasonable thing.
Except how do you get the U&E drawn in community practice when the patient's COVID positive?
That's the challenge.
So I think that would be the challenge.
We do that in a clinic. For patients. We take their bloods and then we can adjust things if we're unsure, but it's really hard in the community.
I think it's really, really hard in the community. As someone said on there, you could maybe through a GPRC might be able to, where they're all PPE'd up and done the stuff. But I think for the average patient, that's going to be, in the average practice, that's going to be very difficult.
I just noticed that we've got a raised hand. Not sure. Stuart, did you want to unmute yourself and ask your question? That hand might have gone down. No problem. Perhaps it was a hand raised in error. So there's a couple of questions just relating to the Liverpool drug checker. So firstly, how do you know if a drug isn't on the drug checker? Does it tell you that? Is the first part of that question.
Yes. Oh, sorry, Jean.
No, you go, Meng. This is your.
Yeah. So basically, like if you plug the drug in, and if the profile or the interaction doesn't come up, then or information about the interaction doesn't come up, then it means it's not in there. In that cases, we have to probably resort to other resources like MIMS as well. Sometimes MIMS interaction checker is also quite a good option as an alternative. The other thing what we do is we look into the drug profile, and if you don't have a pharmacist, we look at the interaction section of the drug profile to see if there's any CYP interactions. If there's no mention of any CYP interactions, then usually generally it is safe. So interaction is not an issue. Yeah.
And someone else has also asked, is it then recorded somewhere if you're looking for it? So I guess this is about sort of, I think, going back into the development of the tool.
Yeah, so there's actually a way to actually request for medications to be added on. I think there's a contact in the Liverpool website as well, where you can send them an email and request for a drug to be added on, so that as part of their profile. Yeah.
Fantastic. So question regarding what about using oral steroids in general practice as treatment?
I wouldn't generally recommend oral steroids unless that was like a severe asthma type exacerbation. I guess you could consider it in that scenario. We use dexamethasone, as I said, for severe, moderately severe patients who are desaturating in hospital. Jeannie, do you use oral steroids?
A little bit like you, Lydia. I think if I was happy it was asthma only, I might. But if I thought that their COVID was bad enough that they were needing oral steroids, I'd probably be wanting someone else to have their eye on them.
Yeah.
Great, thank you. So are inhaled corticosteroids useful for post-COVID prolonged cough and wheeze?
I would probably need a respiratory physician to answer that.
My understanding is like any post-viral cough, they're worth a shot, but not necessarily effective.
Yeah.
Great, getting some tricky ones through. Jeannie, there's a question here around what are the sort of practical strategies for identifying high-risk patients from the GP system data? That might be something that's coming in that one pager that you're talking about that we could share.
Look, the only, at the moment, there isn't anything. So PenCat would be the obvious answer to that. But at the moment, PenCat doesn't have any specific recipes for that, but we're hoping that they will bring us one. And then if you have top bar, that should all kind of talk to each other and give us those high risk ones. But at the moment, I don't think there's anything. If you did it through PenCat at the moment, you'd have to manually set a recipe. You'd have to say, you know, give me my patients who are over 75 and who have diabetes. Give me my patients who are over 75 and have heart disease. So you'd have to kind of manually set the recipes, but you could do it that way.
We certainly might take that for something for us to follow up around some suggested sort of recipes that you could use in Pen to be able to do that. So thank you for that suggestion. Question regarding, can we use oral prednisolone for COVID with severe cough and pharyngitis signs? I hope I've said that right.
I think we already answered that one with the previous. Yep.
Excellent. Thank you. And then there was just a question, Meng, I'm not sure if you know this one, and I don't think it is, but whether interaction information is being fed through to the GP prescribing systems. So the software that GPs use.
I'm not sure. I've not seen the GP software myself.
Bianca, I think the answer is at this stage, no, that they were still relying on MIMS. which I think the first line needs to be the Liverpool checker. So I don't think at this stage there's anything directly coming through.
Yeah, great. So that's all the questions that we had in the Q&A. I'm just going to check the chat. Is there any other questions that anyone had for the panel? Please feel free to raise your hand if you want to ask a question live. So there's a couple of late questions that have come in. I'm working at a GPRC. Our 3 clinics don't have access to venipuncture and usually don't have patient background for their GP. Is it okay to rely on patients themselves? I'm thinking this might be in relation to the EGFR and history.
That's such an individual question. It depends on the patient, yep. I think. I mean, I do a lot of telehealth consultations and you have to make some kind of assessment over the phone about how reliable you think the patient is with their history. And sometimes you can ring up pathology companies and just we have links and we can just check all their blood tests recently. And it's really hard if you don't have that history. Just got to do the best you can, make some kind of judgment about how reliable the patient and their history is. You know, the main thing is liver and renal function. And I think you're fairly okay if they don't have renal risk factors in prescribing. Yep.
Great, thank you. There is a comment here around MBS criteria for prescribing Paxlovid is that either a RAT or PCR should be witnessed by health professionals. I'm very reluctant to invite positive patients to come to my surgery to do a test. Can we take their phone report as proof or to ask a relative to bring the result to the surgery?
I was indicating my irritation at the PBS criteria. Make that sound like we have to do that. We absolutely don't.
Yep.
We're having a conversation with our patient and trusting our patient that they've done their RAT test and it's positive. We absolutely don't want them coming anywhere but at home. And I think the way the PBS criteria is written makes it look like we have to ratify the test, and we don't. We just have to be confident our patient's telling us what they're telling us.
Excellent, thank you. And there's just a comment following on from the drug interaction question that someone has popped in the chat that best practice does have some drug interaction when they last prescribed Paxlovid. So potentially best practice have done some updating with their software. Excellent.
I think the thing to be careful with that though is that most of the GP prescribing softwares use MIMS. So it depends. So, I mean, and I don't have best practice, and maybe best practice has been amazing and has actually specifically integrated a Paxlovid module. But I think that just the thing to be cautious about is that they're probably using MIMS. And MIMS, while it might be useful as an add-on, as Meng said, it's not useful as your primary source of interactions. It's that Liverpool drug checker that should do that.
Great. Okay, so if there's no more questions, I just want to give a big sort of thank you and shout out to our panelists for tonight for joining us on a Monday night. Lydia, thank you so much for your time. Jeannie, the same, and Meng, great to have you involved from the pharmacy hotline. Hopefully your phones will be ringing off the hook after this session. There's certainly some of Jeannie's bookmarks that will make sure that we send around and those kind of key tips. But thank you also for everyone taking the time on a cold Monday night to join us. So really appreciate that. I think the evaluation has been put in the chat, so please take the time to fill that out. It's great to be able to get feedback on what other sessions you would like and feedback on this session. So thank you very much to all our panelists again. A really great and informative session with lots of questions. So thank you very much. Have a good night, everyone.